So welcome back to our series as we just discuss about managing weight in menopause. So my name is Nicoleta Mabena. I'm a medical doctor, epidemiologist, and certified menopause coach. And I support women in midlife to have health, wellness, and quality of life filled with joy and vitality. I hope you can all hear me well. So I do hope that after our last session, you've been giving yourself grace in the past few weeks as you've been going through or moving through your menopause journey and your midlife at the moment. So let's just start off with a few definitions as people are joining, and we remind each other what menopause is, perimenopause, and all. So perimenopause is the transition phase leading up to menopause, right? When cycles, this is the time when cycles become quite irregular and they are erratic, and we've got all these symptoms that begin, and it can even start in your 30s and can last several years. Some have had 10 years of perimenopausal symptoms, which have been hectic. Some people don't experience it badly, but others do get terrible, symptoms. And then menopause itself is a moment. It's when you've had 12 months without a period. That's when we say you're actually in menopause, right? If you are still having irregular bleeding, having periods irregularly, you're in perimenopause, you're not yet menopausal. So once you've reached that 12-month mark, you are now in post-menopause. It's this time when you're no longer having your period, and then this is for the rest of your life. And then when we say you have premature menopause, it's when you are said to be menopause before the age of 40. And then early menopause is when you get into menopause from 40 to 44 years. So every woman, just to reiterate this, every woman who has ovaries and lives long enough will go through menopause, right? The timing varies, the symptoms may vary, and the experience does vary. Everybody has got their own experience, but the biological process is universal. So a rule of thumb for us is that after the age of 55 and you're still having regular periods, we begin to monitor you closely, as these prolonged periods may be due to some underlying cause. Because I've heard some women saying, oh, nothing, I'm still regular and I'm 59. You just need to be checked to just make sure that you're okay, everything is all right, right? So I just want to thank also people who have sent through suggestions as we had, the past few the past week when I sent out the invite for people to register, I asked people to give suggestions in terms of what they would want us to talk about. So we've had some suggestions around hot flushes, around protecting our bones, skincare, remedies for dizziness, memory loss, brain fog, forgetfulness, sex, libido, irregular bleeding, hysterectomies, HRT, mood swings, body image, relationships, and marital problems, and even divorce. So today, though, I want to speak to the woman who's been strong for everybody. That woman who's reached breaking point, finally choosing themselves, right? So this is a woman whose body is shifting, whose patience is grown thin. I think, some of us have been told by our children, our partners, oh, now you don't have so much patience. But I'm speaking to you today. The woman who's setting new boundaries, who's reclaiming her energy and recalibrating herself. The woman trying to figure out who she is. Girl, I do see you. And whatever shift you are going through, whatever changes you are going through, they are really, really valid. And you are backed up by women health and hormonal research, psychological and midlife development theories, sociology and gender emotional labor, relationship and intimacy research, narratives and lived experience research, anthropology and cultural studies. They back you up. So you are valid. So in midlife, women stop overfunctioning. So years of emotional labor, caregiving, and being the strong one become unsustainable as the symptoms intensify, particularly those who have those symptoms that are really bad. Fatigue, anxiety, sleep disruptions, and irritability make it really impossible to keep absorbing everyone's needs. So now you begin to form boundaries. And this is sort of a form of self-preservation, right? So women begin saying no without guilt, choosing rest and protecting their energy, protecting themselves. And this is part of self-compassion. Relationships are recalibrated. Partners, children, colleagues, whoever it is, extended family, need now to recalibrate. They need to adjust to the woman who you are now, as you will no longer be endlessly available to everybody. So for some, it means that divorce becomes an option. And then, of course, we break our silence. We start naming what hurts us, what drains us, and what we can no longer carry. Because, we just then start to question social norms that oppress us. So our identity shifts from pleasing now to truth-telling. Menopause reveals where women have been overgiving, overextending, and overvaluing themselves. This is midlife, guys. And then our emotional clarity also sharpens. So our hormonal changes help us to reduce tolerance for disrespect, imbalance, and emotional neglect, right? So women reclaim their time and space, and boundaries open for rest, creativity, joy. I always talk about joy and, just self-connection. And these are the foundations of midlife self-discovery. So you are valid. I see you, and you don't ever think that what you're going through is not validated by any science or backed up by any evidence out there. So if this speaks to you, it's not selfishness, it's actually a movement. Self-discovery is the essence of midlife. You are choosing yourself, and most probably it's for the first time in decades that you are choosing yourself. Anthropologists will tell you that in our African setting, menopause has historically been viewed as a rite of passage into wisdom and authority. So ladies, we are transitioning or have transitioned into our spiritual and social power. So please celebrate. We are actually powerful, right? Having said that, across Africa, millions of women enter midlife without access to accurate information, supportive healthcare, or culturally relevant guidance. We lack recognition and representation as African women. Whether you are in Australia, you're in the US, you're in UK, wherever you are, you feel like you're not represented enough. And this is not only in science or in research that is out there, it's also even on social media. You hear people talking about menopause, but when you look at some of these things, you think, oh, does this really relate to me? Does this talk to me as an African woman? We are different, and it's actually backed up again by science and evidence. So in terms of biological patterns, our genetic makeup comes into play. We have earlier and more intense menopause symptoms. We have more severe vasomotor symptoms, which are those hot flashes that we get and the night sweats. And we have higher rates of chronic conditions like hypertension and diabetes. And these do interact, with menopause. And I think we will have sessions about these also. Then we look at our cultural and traditional beliefs where there is silence around, just menopause. Even if we try and say something, we may actually not be listened to. And then, of course, there's the climate. For those who live in Africa, it's hot. Some places are humid. And, with climate change, everything is really shifting. Does this speak to us as African women? The diet is different, and our lifestyles are definitely different. Access to healthcare, really, if you are living in Africa, you know that some of these things, when we talk about hormone replacement therapies, can we easily get that? Or even GLPs, now we're looking at patents, the coming down of patents, and hopefully we'll have access to that. So what does this mean for us African women? and of course, our social roles. We cannot deny that wherever you are around the globe, if you are African, there are some social roles that we've got, and we need to ensure we pull that into whatever support we're going to get as African women. So we do deserve menopause information that reflects our lived realities, our cultural context, our biological patterns, and our healthcare environments, and not just based on assumptions. So yeah, so that's why we are here today, to talk about all those things and see how best we can support ourselves as women in Africa. So before I introduce our guest experts today, I just want to reiterate that this is an informal webinar. Conversations are relaxed and designed to genuine interactions and networking and just knowledge sharing. Your mics, cameras, please switch them off. Please use the chat to post questions and comments, and also just send us any messages around what you would want to hear in the next sessions. And we'll talk about the questions. We'll look at your questions after the session at the end. And of course, use emojis. I can see some coming up already to show your reactions. And, it's important for us to make sure that you are there and you're hearing us. So please just send any emojis you want, send questions in the chats. So I'll also be sending out a short check-in. It's an anonymous survey to understand the real experiences of African women wherever you are in the world, navigating your midlife changes. So this information will not identify you. It's anonymous, as I mentioned. And we just want to hear your voice. We want to shape midlife wellness for women. So please complete it when you do have time. I'm also writing a handbook, a Menopause 101 for African women. It's just a quick guide that not only includes medical perspectives, but weaves in African considerations for symptoms, some evidence-based supplements, traditional African remedies, and lifestyle solutions. Be it may, some do not have evidence, but we're just trying to pull it together and tell you that maybe there is no evidence for this thing that you want to do, although there may be, people who've recommended to you, and it's really up to you to take it. But the most important thing is you have the knowledge. So whatever is in that will be really relevant, no matter where you are in the globe, as I mentioned. So last webinar, I gave away Dr. Jackie Mangoma's book. It's called Unshaken to Mary Gold, and she's here. Thank you so much, Mary Gold. I got to meet her, and it was a lovely day that we had. And today I'm going to give away this one called Arise All Women and Pray. So it is a book which is more than a devotional. It is a heartfelt invitation to every woman who has ever faced a silent battle, carried a hidden tear, or waited on God with trembling hope. So yes, someone will get this today. So again, today we have Dr. Vimbayinaishe Kandeke, who will help us sift through the noise around weight loss. Treatments. She's a bariatric physician with 23 years of clinical experience, includes a decade of adult weight and metabolic disease management. She's a clinician who champions new and compassionate standards of care. What I love about the work that Vimbai does is she's got a patient-led partnership between individuals and clinical teams. So whatever you say does matter. And she's the founder of Maitano, a doctor-led digital platform offering current evidence-based advice, non-surgical treatment options for people that would like to help, that would need some assistance in managing their weight. So yeah, so together with Lynn Flowers, where I am from, we come together to try and ensure we give you information that is relevant, evidence-based, and of course, it takes us to where you are, whether it's in the African setting here in Africa or and everywhere else, as you have different biological patterns and makeup that you would need to consider for weight loss. So let's say hello to Wimbai. Wimbai, can you just clap our hands there as Wimbai comes on? Hey, Wimbai, how are you?
Hi, everyone.
Did you manage to rest over Easter?
I did. It was nice and peaceful. What you were saying that we're not available for everyone's nonsense. I took some time to actually rest. So it was nice. It was nice. But then I'm paying for it after the break.
We really validate it. Anyway, so Vimba, I know we don't have much time, so I'm going to jump in. We've got a lot to cover. So let's just start off by understanding the landscape. What are the main categories of, weight loss treatments available today? Be it medical, surgical, behavioral, cosmetic, and how do they differ in purpose and outcomes?
Okay. So we've got our mainstay of, we've broken it up into about three main sections. So we've got our mainstay of treatment, which is really centered on behavioral and lifestyle modifications. So that's where we talk about our nutrition, the exercise, psychological impact, and all those things. So that is the biggest, the strongest arm of treatment that we've got. So unfortunately, it usually takes a backseat. Everybody ignores that and thinks of everything else. And maybe on that one, people will focus on the exercise and think that's what they need. But it's the mainstay of treatment for weight gain and obesity. And then we've got, I mean, it's widely available to a lot of people. So that's why it is our mainstay. And then we've got the pharmacological side of things, where we've got our medical treatments, and we've got a number, so which vary obviously in effect, but we've got things in there. That's where we talk about things like orlistat, and the GLP-1 agonists that we use. To some places use things like metformin and other things, so we can get a little bit into all of that at some point. And then we've got the most effective thing that we've got for weight loss and weight gain, known is bariatric surgery. So we're talking about, again, that also differs in terms of how invasive these surgeries are. We've got the gastric band, we've got the sleeves, the gastric sleeves, and then various forms of gastric bypass. So where you're bypassing the stomach and going straight into the intestines with different levels of invasiveness. So those are sort of main components of treatment for weight management. And then you mentioned cosmetic treatments. So these are things that are targeted to deal with fat, with the fat distribution. They are not treatments for weight gain and obesity. They are, as you said, cosmetic. So it really is about aesthetics. So that's where now people talk about things like liposuction and abdominoplasty or tummy tucks and things like that, which we do incorporate sometimes into weight management treatment, where you've lost a significant amount of weight and you want to manage loose skin and that sort of thing, or you've now got reached a healthy weight, you've got your BMI which is under 25, and you've got little pockets of fat that you want to target. So this is now just to finish the product. It's not a part of the treatment. They don't treat metabolic profiles. They are not weight loss treatments. They are just there as aesthetic supplements.
Okay, all right. So now when we look at the biological mechanisms behind most of these weight loss treatments, how do they interact with midlife hormonal changes?
Okay. So as we caught up last time and mentioned that there's some changes that happen with the changing profile of your hormones. So you've got a differing response to insulin. So we get a bit of insulin resistance. That way your blood sugars are not as managed as efficiently as we'd like for them. There's a change in the pattern of weight gain, where now you're gaining visceral fat. We call visceral fat, so fat around your internal organs. As opposed to earlier in your lives when you're getting a bit more weight around your hips and lower body. So you're getting central obesity, and that comes in. And then we've got changes in your cortisol and stress hormone profiles, as well as your sleep habits and sleep tolerances are changing, which all affect how weight is managed in your body. And then this also affects, so we've got more than one hormone obviously affecting our weight gain. It's not just about the GLP. We've got other hormones like ghrelin, leptin, and all those are also changing, and our sensitivity to them is also changing.
Okay. So what are the biggest red flags when evaluating weight loss products, injections, or just any fat loss, fat melting procedures? What are the red flags? We talk about red flags in relationships, but let's talk about red flags around.
Do we have all night? Do we have all night? So I think as you approach any treatments, I think the first thing you want to do it without emotion. So don't be emotional. So there's a number of things I would say that just make me switch off when I hear some of these things, and scientifically we just switch off. So treatments, for example, which offer no side effects, 100% effective, claims like that, no side effects, as good as GLP-1s, nature's Ozempic, things like that. These sensational claims, I would say, is one of my biggest red flags. So where you've got treatments that don't come with any backing of any trials, there's no evidence for them. It's just or one of them that affects my heart a lot is doctors approve without saying what doctors, when, in what study, how. Or just hear claims like 70% of women using this find it effective, but then there's no true, you know what, this was a randomized controlled trial of so many women, this is what happened, and this is the study. So I would say, if you found a treatment that you want to use, we all have access to the internet. I would say go on there, use, PubMed, Google Scholar. You use it for all your other important findings. Use it for this one. Go and see if there's any studies for these treatments that you want to trial. Another red flag for me is treatments that offer that are based on before and after pictures or testimonials. I know people love to hear testimonials, but that is not evidence. And you were not there to see how this information was collected. And we also know about how much we can manipulate images. So before and after pictures are not a good way to prove a treatment works. It will convince you, so my so-and-so used this, they lost 10 kgs in 1 week. Those are big red flags. Also treatments where the ingredients lists are not clear. You just hear, it's a proprietary combination, or Amazon rainforest concoction, or whatever. Things like that are also big red flags. So we should be able to trace what the active ingredients in all these things are. And then when you do find out what the active ingredients is, again, please use the internet for good. Find out what the side effects are and all those things. And then other claims such as it works for everyone, that is also a big red flag, because it definitely cannot work for everybody, because it doesn't take into consideration your personal genetics, your biology, what are the medications you're on, what the conditions you have, and all those things. So those are sort of like I could go on that one for the whole night, but I think those are big ones. And then or anything that claims to be a detox, big red flag.
We're trying to detox ourselves.
Yeah, so no, run from anything that claims to be a detox. Run.
Okay, so I know we could go on, and I could add some more, but let's just understand bariatric medications now first. Let's talk about GLP medications. They are now everywhere, and last time we talked about the patent dropping, and that generics are becoming more accessible, right? So what should women know about safety and quality and regulation? So, because chances are someone is going to come up and say there's this that is available. What should we know, and what should we look out for, really?
So with GLP-1 medications, what we're calling GLP-1 medications are, it's glucagon-like peptide agonists. So these are medications that mimic a hormone that we've got in our bodies called glucagon-like peptide. And so this hormone exists, and we know that even if we try to enhance it by injecting, or the human form of it, it doesn't last long. It's broken down by our enzymes and other proteins in our body. So this is why now the GLP-1 agonists come in and are very useful, because they last a lot longer than our own natural GLP-1, and give us the effects that we want, which are, you're quicker to get full, you're fuller for longer, your blood sugars are better managed, and you've got less food-seeking behaviors. So which all add to you really reducing the calories, obviously, you're going to be eating. Hunger spikes, your metabolic profile also improved. And then we've also, along the way, started discovering other useful non-appetite related effects of these GLP medications. So it is, for example, improving our cardiovascular risk, for example. There's work in addiction therapy and all those things. So these are just an evolving plethora of effects that are useful. So you mentioned about what we need to know. You spoke about, you also mentioned the patents expiring. So the patent for Wegovy, for example, is, so I mentioned Wegovy. So the examples of these medications, obviously, we've got Ozempic, and which is what we use for diabetes. And then we've got Wegovy, which is the one that's licensed for weight loss. And then we've got tirzepatide, which is another one, which is manufactured by Eli Lilly, which is sold as Mounjaro, which is for diabetes. And for weight loss, we've got Zepbound. But people tend to use Ozempic and Mounjaro as interchangeable but we need to understand those are preparations for diabetes, and then we've got the preparations for weight management. And it really used to do with the dosing and all that comes with that. So these patents, so I'll speak on Wegovy, which is what we're talking about when we speak about the patents expiry. It's held by Novo Nordisk. So what that means is other manufacturers will now be able to manufacture the generic forms of that which is semaglutide. So they'll have their own semaglutides and name them what they want as their trade. So currently the trade is obviously Wegovy. So what that means is we've got it's countries like China and India, which we know are also helpful to us in Africa because we tend to get our generics a lot from them, which means with time we will be able to access better priced and more volumes of these medications. So as it becomes more available, what I would love everybody to know is these are medical treatments. And let's treat them as that. These are drugs. These are powerful and useful drugs, which we are very excited about because they've got real metabolic effects, which are changing lives and saving lives. And we want to preserve them for that and save them from all the hype and noise that come with that. If we calm down from the excitement and the sensationalizing and understand these are medical treatments, and therefore I would say treat them as such. You want somebody who is trained and experienced enough to be able to prescribe this, just like you would with all your other medications. You're not going to just, oh, this is what my sister is using, so I'll just jump on that. You've got to have an assessment for yourself. You speak about red flags. I would say anybody who's offering you these treatments without assessing you fully and doing any metabolic testing for you, that's a big red flag. Or people will tell you that you're going to be on this and you'll be fine or whatever, that's a big red flag. So what you want to anticipate with these medications, so we briefly spoke about obesity on our last chat, that it's a chronic medical condition. It relapses and waxes and wanes, and it's not curable, but it's manageable, just like diabetes, just like hypertension. So if we, and then it also has, it's multifactorial. So there's many things that contribute to weight gain and obesity. So if we understand that this is a chronic condition, we must expect our treatments to be chronic. So it's not a 2-week treatment. It's not a, so for me, as I research my patients and try to figure out who's suitable for these medications, anyone who's looking for a quick fix, or I just want to drop a dress size for a wedding or whatever it is, for me, those are not suitable patients for these kind of medications. These are chronic medications for a chronic condition. So if you understand that, then you also understand that you expect to be on it for a prolonged amount of time. And then I also understand that this medication is treating a condition that exists. So if you withdraw the treatment, that condition will be unchecked, and therefore the weight gain will resume again because it's not a cure It's a treatment to manage the weight.
Yeah.
So,
Absolutely. Go ahead. Go ahead.
or I could, okay. So,
You could go on forever.
and then in terms of why the patents, so you spoke about patents, and I think it's also a good time to speak about compounded medications, because I think countries like Namibia and South Africa you probably find compounded. In America, not so much. Countries like UK and Zimbabwe, you're not finding those a lot. Where pharmacies are allowed to mix up their own of versions of these medications that are not as widely available, that are in short supply. So, but then the issue with that is it's a pharmacy that's its individual pharmacy does its own compounding. And you don't know what you're getting and what the dosing's like. You can't control that. And some of them will not even allow you to take the drug home. They'll say you need to go somewhere to get it injected. So you can't even control what, I should have brought a version. So what you get is self-administering pens. That's so you're not changing the dose. It's set dose. That's important. So I would say, if you can, please get a treatment like that, where you've got a set dose in each pen. So you've got your 4 doses in there of a set dose, so you know what you're getting at every point. You're not twiddling, you're not fiddling, because that affects what you're getting in terms of the bioavailability of the medication, the safety of it. You don't know what else is in there. And then big thing, these medications are tools to help us with my mainstay that I discussed earlier, the nutritional and the exercise and the behavioral and the psychology and all that. So you've got to focus all your time and effort on that arm of everything, and these just help things along.
So, I mean, it's very interesting. You talked about compounded medications, and you know that, some countries really do it a lot. And we're talking about Nigeria. Nigeria does it a lot. And, here in South Africa, we get quite a lot of compounded medications. So, ladies, I mean, just take note. And if you're going to just get someone giving you something without really assessing you, you know that, again, as Vimbai said, this is a huge red flag. So I'm just going to jump to bariatric surgery, because I know the bariatric medications we spoke a lot about last time. And I know someone who actually says they're about to go for a gastric sleeve, and they are actually happy that we're talking about this. So what exactly qualifies as bariatric surgery? How does it differ from cosmetic procedures like liposuction and tummy tucks? I know you touched a little bit on that, but can you just explain to us, what is this really? And yeah.
Okay, so we spoke a little bit about the biology of weight management and appetite control. So this is all done by neurohormonal mechanisms. So we've got an interplay between the brain and the hormones that are produced mainly in the gastric area. So you're talking about the pancreas, the intestines, and the stomach, and then the metabolically active fat. So there's all these hormones that are in play to manage your appetite, control your weight, your blood sugars, and all those. So what bariatric surgery does is so obviously, so that's what we're calling a metabolic profile. So bariatric surgery alters your metabolic profile. So we've got, I mentioned, so you've got a gastric band, for example. What it does is, you are essentially putting a band around the top part of your stomach. You reduce the volume of the stomach, and you're also cutting off some areas of that are active in producing some hormones that help in appetite engagement. So, and then you take it further when you do things like gastric bypass, where we are bypassing the stomach and you're going straight into the intestine. So remember, we said that GLP-1 is made by the intestine. So we're activating the intestines early, so you get your own GLP-1 produced a lot more. So that helps to now manage all those other things that we're doing with the medications. So it's a metabolic surgery. So it's not just called bariatric surgery, it's metabolic surgery because it alters your metabolic profile. And so you find people who've had bariatric surgery, for example, they're able to come off their medications for diabetes. You can, as far as sometimes you get up to 70% of people who had it done. People are able to reduce or come off their blood pressure medications because those are all metabolic problems that are resolved by bariatric surgery. So it's the most effective treatment that we've got for weight gain and obesity.
Okay.
Now, compared to cosmetic surgery that we talked about, it's targeting fat outside. So we spoke about visceral fat. So the fat around your tummy, your internal organs is what is metabolically active. So that's what the only way we can deal with that is by generalized weight loss. But now these cosmetic treatments are just coming and targeting, I've got a mummy pouch, so you got a little bit of fat, you got a liposuction that fat, or an arm here and all that. That is not going to improve your health. That is not going to change your blood pressure. That's not going to change your blood sugar control. It's not going to give you overall weight loss. But on the other hand, if you had metabolic treatment for your weight gain, you would lose all those other bits of fat, for example. So there's a difference.
Yeah. So who is considered appropriate or an appropriate candidate for bariatric surgery? Can I just go in and say I want bariatric surgery and just get it done?
So you would have to have a lot of assessment. So there's things that we're looking at. So most guidelines are quite similar. I think we've just lowered it down to a BMI. So it also depends on obviously your genetic heritage. So where we're looking at lower BMI thresholds for certain genetic profiles. So maybe South Asian people, for example, would have it down to about 30, BMI of 30, and then everybody else you're looking maybe a BMI of about 35 or 40, depending on where you are in the world, to say you're a good candidate. And then also the presence of metabolic disorders like hypertension, prediabetes, diabetes itself, lipid profile problems, they also contribute to you being accessible to bariatric surgery at a lower BMI. So to answer your question is, no, you can't just walk in and say, I want it. If you're dealing with a legitimate facility, they would need to do all these things. So they're looking at your blood profile, they're looking at obviously you and everything. And then also your health, your general health. Some people are maybe not that healthy. They've had heart problems, they've got liver problems, which might not make them suitable for bariatric surgery. And then commitment to follow up. So bariatric surgery is permanent. There is no, I'm just going to wake up. I've lost my weight in 6 months. I want it undone. It is permanent and it requires a lifetime of follow-up and supplements. And I mean, obviously, we're not talking about a gastric band, which is a temporary fix, but I'm talking about the gastric sleeve and especially the bypass surgery. It's a lifetime of follow-up, supplements. So it's a commitment to that. So that's another way of choosing a suitable candidate, somebody who's committed to a lifetime of showing up for blood tests and all those things. So I think those are, and then age, we're doing it with older and older patients. I think we can now up to 75, we can. And then we also got younger candidates now with all the obesity that we're getting. But generally, 18 to about 75 would be a good place to start.
Yeah, so let's talk about us midlife women. So how effective is surgery then for long-term weight loss? Because we talked about it being permanent and you need to have constant, reviews and checkups and follow-ups, and you need to be on supplements and the like. So how effective is this, in terms of long-term weight loss?
Okay, so I'll give you a little comparison so that you have a little bit of context. So if you did perfect with the behavioral nutrition and psychological modifications, you can lose. We expect people to lose maybe about 5% of their weight loss of their total body weight in maybe about we say in about 12 weeks.
Okay.
And then if you introduce the pharmacological interventions, so the medications, so it depends on what medication you use. So I think maybe some of the more famous ones, I don't know if you've how many of you have heard of Orlistat, for example, or Xenical? Probably, I mean, over the counter would have been Xenical, wouldn't it? So, or Ali, or things like that. So,
Yeah.
and phentermine, I think South Africa, there's phentermine, things like that. So you're looking at about maybe 5 to 8% of your total body weight in that 12 weeks with those medications. So kind of modest, definite, but modest. Certainly better than apple cider vinegar, for example, which will give you 1 to 2 kilograms over, I don't know, 6 to 12 months.
How many months you'll be drinking that? Yeah.
We introduced the GLP-1 agonists, for example. They'll give you, in good hands, up to about 25% of your total body weight in that 12-week period. So that's really, really, really good. Now, with the more effective forms of metabolic surgery, we're talking about up to 35% of your body weight lost. So that is amazing. That is really amazing. And then you're asking how effective they are. So we then look at what happens with time, what happens in a year, what happens in 2 years. So, I mean, we've had people followed over 10 years, for example, in some studies, you get 15 to about 20% of that loss maintained after about 10 years. So that's really amazing. So how effective it is? For women of this age, I think it is very effective. For women, for perimenopausal and menopausal women who are suitable candidates for it, it's certainly an effective and well-studied form of weight management. So I would say yes, and then obviously it then deals with things that are happening in that perimenopausal space. This is now where we start having the hypertension, the diabetes, and all that. So it has a nice rounded effect. So I think it's fantastic.
Yeah. So now we have to talk about risks and complications.
About what? Sorry?
Risks and complications.
Yeah, sure.
Really well. I don't know if you can hear me now.
I've heard you.
Yeah, risks and complications. What should women be aware of, both short-term and, of course, long-term?
So is this with reference to metabolic surgery?
Yes.
Okay.
Metabolic surgery.
So we've got some, you rightly divided them into short-term and long-term. So the short-term tends to deal with more things that can happen with a lot of surgeries that happen anyway. So we're talking about the immediate so there's immediate and then the short-term one. So short-term is you had your surgery, you've come out. We're not dealing with the on-table complications, you've come out of it. So we've got wound risks, so bleeding from that wound, infection of your wounds, vomiting, potential for blood clot formation after that major surgery. And then obviously pain, things like that. So that's in the sort of short term, but these are things that are sort of manageable and anticipated for all forms of surgery, in all fairness.
Yeah.
Then with particular reference to metabolic surgery, now I think we're more interested in the short to medium to long-term complications. So we've either cut off parts of the stomach, joined to the intestine, so you can have ulcers around those joints. We call that anastomotic ulcers. You've got things like adhesion, so you've obviously irritated the surface of the lining of the abdomen, so you can get adhesions, which can lead to other problems like bowel obstruction. You get adhesions that can give you vomiting now in the long term, because now you've blocked off all sorts of things. And then there's things like dumping syndrome, where we've bypassed the stomach, so all these the fat and the sugars, especially if you're eating high fat and high sugar content food, going straight into the intestines can give you vomiting, nausea, sweating. Some people even faint, and all those things, which you call dumping syndrome and things like that. And then obviously malnutrition, if you're not eating enough protein, you're also not getting your supplements, so you can have micronutrient and vitamin deficiencies, which also need to be followed up. So, and then we now look at long-term complications in the psychology. So maybe you've lost all the weight, and sometimes people have unhappiness with their bodies after you've lost all that weight, and sagging and
Yeah.
so forth and so forth. So there's
Now you need to go to cosmetic surgery now.
yes, so that is something that we can use cosmetic surgery for. It's not, I mean, people say, oh yeah, I've heard that you've got to have cosmetic surgery after bariatric surgery. It's not everyone who needs that. But yes, it is a tool we can use to help satisfaction with the body.
Yeah, yeah. So myths around bariatric surgery?
Oh, loads. So I've just mentioned one, where people think that you've had bariatric surgery, you must have cosmetic surgery. No,
Yeah.
not everybody who's had it.
Mhm.
And then they think, oh, oh, there's one where if you're like, oh, it doesn't matter what you eat because you will vomit anyway and you'll lose weight. If you are vomiting after bariatric surgery, there's a problem. You're either eating
Yeah.
too much, too frequently, or the wrong sort of thing. So and that's something that's discussed obviously when you're preparing for your surgery and afterwards. Other myths, you can eat whatever you want whenever you want. That is not true.
I've heard that a lot.
Yeah, you will never ever gain weight again. That is not true. We've got patients who've had bariatric surgery and some weight regain can happen. And then we still need to go back to that arm of the behavioral, nutritional, and then sometimes we even introduce medications like the GLP-1 to help things along.
Okay, yeah, yeah.
Oh gosh, there's quite a bit.
There's quite a bit, yeah, there's quite a bit. So I think let's move on now to cosmetic treatments, because I know some people want to talk about this. From a medical and metabolic perspective, what should women understand about the risks, limitations, and long-term implications of BBLs? I'm just picking BBLs because I know
You went straight for the BBL.
for the BBL.
Okay,
And how does this, you've told us how this compares to other weight loss treatments. So we won't talk about that. But what are the risks and limitations, long-term complications? Because we've seen a lot of it online.
So, I mean, a BBL is an aesthetic treatment. It really is just about contouring your body. Okay. So you can decide to have a BBL to do all that. So, so essentially you're just liposuctioning fat mainly from the abdomen, upper body, and injecting into the buttock. So we're just redistributing that fat.
Yeah.
So the risks, there's obviously risks that come with surgery. We spoke about some of them, infection, bleeding, and all that happens outside theater. And then there's a particular one where we spoke about, we're injecting fat into the buttock. So fat, when it enters our blood vessels, is not something we need in there. That's what we call embolism. And so most of the BBL deaths that you hear about are because of fat embolism, where you've had fat introduced into a blood vessel, and that causes essentially, cardiac failure and all those things. So that's a big, scary one. And then another one where fat cells can die. We've introduced them, taken them from their home to somewhere else. They might not revitalize. They can die. So again, that might give you infection or uneven results.
Yeah, and then you have one that's bigger than the other.
Yes. And then we can also get fibrosis. So you get now little lumps, all those things which people can be unsatisfied with. And then, yes, again, it can all just shrink right back down because it's not meant to be there. So that can happen. So I think those are the main ones, sort of uneven results, fibrosis, embolism, and that sort of thing. Yeah.
And there's a lot of pain also, I understand.
Oh, absolutely. Yeah, it is a very painful procedure. It is a very painful procedure. And then also the volume of how big you want this BBL. Sometimes is a bit unsafe. Sometimes people want to just keep going. I know somebody who's gone like 3 times. So you've done it, gone back, and that adds to the risk. And then yes, it is one of the most painful procedures out there. It is painful.
Yeah. So online there are a lot of fat melting injections, body sculpting, and sport treating our belly fat. I mean, we talked about this last time. We want it off, guys. Everybody wants this thing off. So we're seeing a lot of this online. So do these treatments work? And what are the biggest, again, red flags that women should look out for? I think you've mentioned some, but what do we do as women? Mm.
So what you're referring to as pod treatments for fat is, um, claims to reduce belly fat or reduce arm fat and all those things. So one, you can be offered injections, what people want to call fat melting
Yeah.
injections. So it's usually drugs like deoxycholic acid,
Mhm.
where injected into a particular little spot, they will kill off the fat cells and then flatten that area. So but to be honest, the only one that's regulated is deoxycholic acid for that,
Okay.
for the one. But then it's being used off license to treat belly fat.
Mm.
So we spoke about, these are not weight loss treatments.
Yeah.
Okay. These are not weight loss treatments. You got the injections, you got cryo, where you're fat freezing, fat laser, and all those things, which come with their own complications in that area. So you can get burning, you can get, again, uneven results. Fibrosis happens as well. And then you get little hard spots in there, and which again adds to the dissatisfaction. So to answer the question, do these treatments work? Yes and no. Yes, in that, yes, you can kill off a few fat cells, but it's not a treatment it's not a weight loss treatment.
Yeah.
So I would say maybe you've achieved your BMI under 25 and you're feeling trim and you just got a little something that you feel, I've been little pinchable bits of fat that you say, I want to get rid of. You can do those treatments. Not where you are sitting there, BMI 35, and you think, I just want a slender waist or I want to lose a bit of weight. It's not going to be effective to the way you want it. It will be expensive. I would say use that money, buy a good pair of shoes, go walking, invest in some good food, and if you must, invest in some good medication.
Yeah. And also the fat will come back.
Absolutely. And you do, and then what happens sometimes is the fat is gained elsewhere.
Yeah.
So, and then also important to remember, you've dealt with the fat under your skin, but the important fat is the fat around your organs. So it's still raging in there. You're still metabolically active fat in there. So you're still at risk.
Yeah. Okay, so let's jump to exercise, for weight loss in menopause. So many women say they exercise more, but nothing is changing, really, no weight loss. So what's really happening to us physiologically? How should we rethink this approach in terms of exercise? What should we do?
So this is a nice one because you hear a lot of people exercising a lot, and especially start of the year, everybody's out there, they're running, they're doing the exercise. I've been exercising. I would say as a start. I mean, we'll get into it. If you're exercising, I'm exercising 5 hours, 5 hours a week, nothing has changed. Then we need to look a bit deeper. So exercise, yes, is great. And I think everybody must exercise. We definitely must move, especially in the perimenopause. It's just the nature of the exercise that we're doing and how frequently we're doing it. And then what else we're doing around the culture of exercising.
Yeah.
So exercise is great for your cardiovascular risk. It strengthens your heart. It helps to maintain your muscle. We spoke about perimenopause and what's happening with that, with the hormonal change. We're losing muscle. So especially weight training and strength training helps us to maintain that muscle mass, which also then helps to hold on to what's left of our metabolism. And it strengthens our bones and everything. So exercise, we must. But now, with particular reference to weight loss, exercise is very inefficient for weight loss. For example, you want to do, if you want to burn, if you burnt, I don't know, 300 calories on your treadmill and you eat a muffin, that offsets it. As small as a muffin, it offsets it. So it's inefficient for weight loss. You'd have to exercise a lot. I always say to lose about a pound of fat, you need to run about 35 kilometers.
Mm.
So it's
So
not
you're
very.
marathoning every day,
You're
every week.
marathoning every day just to lose a little bit. So,
Yeah.
but the benefits that, and then what also happens to people when we exercise, especially when you're exercising a lot, you feel you deserve, I've worked hard, I can eat a little bit more. I can eat a little bit more. That's number
Yeah.
one. Number two, some form of cardio will actually induce appetite. So
Mhm.
it's not even your choice. Your body is trying to maintain a certain set point, so you will have more appetite and eating more.
Mhm, mhm,
So that also then offsets the exercise that we're doing. So to answer your question, I think exercise is crucial. It's important, but we need to know why we're exercising. Exercise can also be useful as a form of weight maintenance. But for
mhm,
weight loss itself, it's not the most effective thing.
yeah,
So I wouldn't put it at the top of,
mhm,
oh, I want to lose weight, I'm going to exercise. I would say let's look at what you're eating and how you're eating and when you're eating. And
mhm.
then let's incorporate exercise for all the other benefits that we discussed in perimenopause and for general health for everyone.
Yeah, yeah, true. Because we've really been going to the treadmill there, and also, we just need to remember the issues around our muscle mass and our joints, and just maintaining strength, because we really need to be able to get up, and move as we get
Absolutely.
older. We don't want to be those old women who are just sitting down. So you exercise for that purpose. So as Mbai is saying, really trying to exercise for weight loss alone, using that as a tool alone, yeah, we need to really move away from that. So let's push to nutrition. Yeah, this is a big one. And I think maybe we should just dwell on it a little bit.
Okay.
What should midlife women think about nutrition for weight loss when hormones are shifting, and what dietary patterns actually support metabolic health during perimenopause, especially during perimenopause when our hormones are everywhere,
Yeah.
up and down. Yeah. So yeah, what
So
should we?
I'll say as a start, this is one area that you do need to be quite discerning about the red flags. Okay, so there's a lot of red flags when it comes to our nutrition and what we're eating, and there's a lot of myths that affect how we're eating
Yeah.
at this point. So this is a nice time to start sifting through all that and dumping them. So we'll touch on a few of those as we talk.
Mhm,
So I think when it's what you're eating, when you're eating, and how you're eating. So I think
mhm,
it starts with understanding your own pattern of eating as a person. It might require obviously someone to assess a weight management service to help you assess your eating pattern as a person. You've got emotional eaters, you've got grazers, you've got those that want to have one big meal a day and all those things. So there is no one method that works for everyone, but you've got to understand at the end of the day, it's what calories in total that come. And then what is the makeup of those new calories that you're consuming? So not
mhm.
all calories are the same.
Yeah.
200 grams of a donut, 200 grams of fish and broccoli. I mean, 200 calories of a donut, 200 calories of fish and broccoli are different things, and they do different things to our bodies. So
Mm.
in this phase of your life, you want to eat things that are going to keep your blood sugars as level as they need to be. We're fighting with the insulin resistance. So we want to not challenge our poor beta cells that are left with bombard them with all sorts of sugars and all those things.
Yeah.
So I would say prioritize protein as well. We're trying to maintain our muscle mass.
Mhm.
We also want to continue feeling fuller, so this protein helps. I'm not saying eat 20 kgs of
So
protein.
for more count.
No, we're not eating the whole cow. You're probably looking at about one to 1.5 grams per kg of body weight per
Mhm,
day, per
mhm,
day. And then, so what you also want to do is split this protein across the day, because it does different things for you at different phases of your day.
mhm,
People, breakfast tend to really suffer for protein, for example. People tend to have a lot of carb-heavy breakfasts and don't think too much about their protein and then save it for their evening meal.
mm,
But then you sort of need it across the day. Again, we spoke about feeling fuller. protein helps you feel fuller for longer. So if you're doing it across the day, you've got a better chance of maintaining your total calorie intake. And then people demonize carbohydrates a lot, which is quite sad, because carbohydrates are important food for our brains. We do need carbohydrates. The question is, what kind of carbohydrates are you eating?
Yeah.
So I would say you want a lot of fiber with your carbs. So as much whole foods that you can eat as possible. You can still eat your sadza, you can still eat all this, but you're looking for the more fiber dense options, and also include other carbohydrates from vegetables to go with your carbohydrate and your protein. So it's not just, so when people think of carbs, just think of bread and pasta and all those things, but there's a lot of other things that we eat are carbs, which are helpful to keep us going. And then timing of eating, people, there's also this drama of everything you eat after 8 is just going to be on your hips. That is not true. Again, understanding your patterns as a person. When do you prefer to eat? What's your day like? And then you can structure your day appropriately so that you're not straying too far from your own natural patterns. So this is something we also help people with in our practice, trying to figure out your own natural patterns. That's sort of the main, and then you talk about nutrition. This is where people now talk about intermittent fasting and all those things as we talk about the different patterns of eating. So intermittent fasting is a big buzz. It's been for a few years now. There are trials that compare, obviously, the intermittent fasting to a general calorie deficient, a reduced diet, and you find it's comparable, because the idea is they're doing the same thing. You're reducing the overall calories that you're consuming in a day or in a week, whatever it is, depending on what kind of fasting you're doing. But I think intermittent fasting deserves a bit of mention in this group of women, in our perimenopausal selves. When people do prolonged fasting, for example, you're stressing the body, for example. We're then increasing the cortisol. We're increasing, disturbing our sleep. We are irritable. We are doing all this, which is counteractive to what we're trying to achieve. So I would say intermittent fasting, yes, it can work, but don't have a very long fasting periods. And then what you're also eating when you're off your fast, because people think, oh, you can fast, you can eat whatever you want in that 8-hour period, or you can eat whatever you want on those 5 days that you're eating. That is not true. We still need to come back to the core of how we distribute our nutrients and the quality of the nutrients that we're eating during those times. And so that's
one thing that comes at the top of my head is, our plates. We use these huge plates, and then you've got this pap, the sadza, that we half of it is my sadza, and then a little portion is just the protein or the vegetable, whatever it is. What do you recommend for us to do around, our dishing skill, how we dish food and things like that? Yeah.
So one of my favorite things, which works, is I know people love. We've had a lot of nice, beautiful, big plates that show up a compartment here. Maybe not use that. Just have. I would say start with a 25 centimeter plate. As your go-to, and then you can top up as you go. And then we then want to distribute, I think I'll share with you some of these portioning plates. So I would say maybe rule of thumb, if you're gonna go for a sadza, go for your fist or your rice or whatever. Just a fist on that plate should be your carb, and maybe another fist and a half, that'll be your protein, and then the rest can be vegetables. And then try and go for the vegetables first, and make sure that so whatever else you're eating, you're able to regulate the blood sugars that you're absorbing as well. So, and mix the vegetables, mix the textures, mix the colors. So it's not just, later I've had a bit of sadza and rib, and that's enough. You can add carrots, you can add peppers, you can add all sorts of things. They also add to that layer. And then different textures mean you're chewing for longer. It's important to chew for long. It helps your brain register that you've eaten. So the more fibery bits you're chewing for longer, the more you're going to feel fuller quicker. And then if you finished that plate and you still feel hungry, you can try and repeat the same, but don't just, if the problem is once food is on your plate, you're bound to finish it, number one. And also one big thing is, we tell this with parents for the children, but it's true for us as grown-ups, not to eat in front of a screen, because you're going to have some mindless eating. Your brain doesn't register that you've eaten. So focus on that meal. Enjoy, savor it, and then you're bound to feel fuller. So yeah.
So I heard you saying start with the veggies. Is it is it actually a thing that you need to start with?
Yes.
When we eat, when you're eating your pap, you're gonna go like that. How should we eat? Maybe let's have eating etiquette in midlife. What do we do?
Okay. So when I say start with so I would say, okay, maybe you want a bit of the pap, the sadza, the fufu, the whatever. You want a little bit of it, but for the taste, perhaps. But let the bulk of your mouthful be vegetables.
Okay.
Yeah.
Okay.
So it's almost just for a bit of taste, and I mean, you think about it. You don't need 200 grams of, and it really loads your blood sugar. 200 grams of sadza, for example, two lumps of sadza will load you with probably as close to 20 cubes of sugar. So the vegetables are also important, because then they help to maintain your blood sugar levels. So what we call the glycemic index, for example.
Yes.
So that's why we want to mix them as much. So I can't overemphasize, much of your plate, let it be the veggies. Go for them. Go hard for the veggies. Finish your protein, and you'll find sometimes you won't finish your salsa, but it's just almost reimagining how you're eating.
Yeah. So what myths do you want us to stop as believing around eating?
You can't lose weight. You can't lose weight on sadza and fufu and rice. Not true. It's just how much you're eating, what else you're partnering it with. So yes, I say people who lose weight successfully are people who eat things they enjoy and they can sustain eating. Because remember, we said this is a lifetime. This is not, I'm going to do this for a month and then stop. So you want to enjoy what you're eating. So it's just focus on how you're cooking your food. If you don't add fat if you don't need it, and then, or find ways of delivering fat that you can control. So maybe using a spray bottle instead of just pouring. That's another myth. Or speaking of oils, another myth that olive oil is better. We need coconut oil. We need.
Yeah.
They're all fats, and they're all high in saturated. They're all fats.
They're all gonna end up in the same place.
They're all fats. And then, another myth is what people are calling clean eating.
Yes.
Clean eating has taken many forms. It could be anything from avoiding dairy, avoiding meat, eating only organic.
Yeah.
And all that. That has got no effect on your weight, because at the end of the day, these are proteins, these are carbohydrates, these are vitamins, these are whatever it is. It doesn't matter if you went and bought them in Woolies, if you bought them in M&S, if you bought them in wherever, in Aldi, you bought them in OK. They are
proteins, and they are carbohydrates, and they are fat.
Look at food as that. So there's no food that is bad. There's obviously things that we want to eat less of.
Yes.
But the food is not inherently evil. So you can eat a cake every so often. You can't eat a cake every day. You can't eat a whole cake every day. You might have a slice of cake on your birthday, or you know what, I'm really craving a bit of this. But portion size is important, frequency is important, and not once you've sort of made certain things a no-go, they become the one thing you think about.
You think about, and it's buzzing in your head. I want to eat the cake, you know.
So I'd rather you have your little sliver of cake and get over it and get on with your day.
And move on.
Because if you don't, by the time you do, you're eating the whole cake.
Yeah. So I think it's got to do with us also consciously making some of these decisions around the food, you know, because what we take in is also what then ends up being part of our being, right? So yeah, you know, I like the issue around the plate, you know, it's very good, but let's
So
see how.
that grace we spoke about does
Yeah.
not only extend to our menopausal changes. It's
Yeah.
how we perceive food, how we eat, how our bodies process this food, how we look. You know, you're not gonna change. So, and then also understanding that in this perimenopause and menopause, your body is genuinely changing. And it will definitely have changed. It's not going to go back to the way it was when you were 16, 18. And
Yeah.
just understand this is how you eat. This is what you'd like to eat. How can you improve it? How can you make it better? So this is where working with with professionals, with weight management services and all those things, you can also almost just reframe everything, just a reevaluation of where you are with everything in terms of your health and everything.
Yeah, and also eating what food you like, you know, but looking at the portions and like what we say, because I think we often restrict ourselves in terms of food, and we
Yeah.
are miserable. Then we binge eat. Then
Yes.
it now becomes a really huge vicious cycle. We feel bad. Now we are stressed. Cortisol goes up, and
You've denied yourself at supper, so you're still hungry, you're thinking about eating, you're not sleeping well at night. Sometimes you're better off just having a little bit of a biscuit or something and go to bed, not thinking about being hungry, and actually get some rest.
at least they have some rest. Yeah. So again, grace comes in. So the last segment, you know, the last issue that we want to talk about is herbal, natural, and supplement-based treatments. And I think this is huge, 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 huge. In particularly in our settings where, you know, we think that if we go natural, you know, this is the way to go. So herbal and natural weight loss products are heavily marketed to us. That's a fact. What's your take on these treatments for weight loss? And I know you've touched on it, but just sum it up for us a little bit.
Okay. I think, you know, you mentioned natural. I think when people hear natural, it's almost just anything that is not medical is being touted as
It's
natural.
natural, yeah.
And not necessarily true. And then again, not everything natural is safe or good. So when we look at the natural and so non-medical, let's say non-medical ways to manage weight, there's many ways people attempt to manage their weight. So it can start from you know, home remedies. So I think everybody's like, oh, lemon water. We spoke a little bit about apple cider vinegar. You know, yeah. So some of these treatments are harmless. They are harmless. Some of them have some little bit of effect. So you look at, we spoke about apple cider vinegar, it's got some little bit of effect, but then you're obviously, how much apple cider vinegar can you safely take? Is a question, and how do you take it? So you also want to enjoy it. I would say if you're gonna go down the apple cider vinegar, you've committed to yourself, I want to lose this 1 to 2 kilograms over the next 6 months, and that's what you want to try, by all means, but then do it safely. So I'd rather you used it in your salad dressing, for example, or dilute it into your water for the day instead of just spoonfuls of apple cider vinegar. That wreaks havoc on your teeth and irritates the mouth as well. And then things like lemon. Lemon has been touted to burn fat because it's all acidic and all that. It is not a fat burner. It tastes nice. It might help you digest your food a little bit better and helps you with your rehydration. If you're drinking lemon water, by all means, I've got no problem with that, but it is not going to change your weight. And then you've got, things like people talk about ginger and all those things.
Lemon
These
and
are
things.
all safe things that you can incorporate into your diet.
Mhm.
I don't think it serves any harm.
Mhm.
But then when you now start talking about things like the supplements, or you got things like green tea extract, the berberines and all those things, then that now become a bit more pharmacologically active. So you now also want to consider how much of those things. So you're buying supplements now. You want to know how safe are these supplements?
Yeah.
What is in this thing that they're telling me it is? And then also ask yourself, why do you trust that more than the next drug that has been studied and is under control and is under monitoring? What is it what is this benefit for? I've just had a supplement.
Yeah.
And then we spoke about the effectiveness of these remedies. You want to find out, what are the studies saying? What is the evidence? For these things that I'm going to pay, and they tend to be a bit pricey as well. You're paying for it. You want to know it's effective and it's safe. Who's making it? What else are they putting in there? Because sometimes some of these companies, they will put pharmacologically active actual medications into these things. So, like sometimes they'll sell a herbal supplement for men to improve their virility, and then they add a bit of Viagra in there,
Yep.
but then that's not declared or monitored. So it is very important. I think just be very discerning. One, who is making these claims? Who is selling these these supplements? Why do you prefer? What is it that you're avoiding by
Yeah.
thinking this is a better form, when sometimes it's not going to give you the effect that you want? But let's talk about those things. And then a lot of these are not substitutes for medical treatment. So, for example, you've got blood pressure. You're meant to be on blood pressure medication. I've had a patient who decided to come off their medication because now they're taking beetroot tablets. We won't say no, I can't stop you from doing it, but we'll then check how much reasonable lowering of your blood pressure can you get from these beetroot tablets compared to your blood pressure medication. So I think as women of a certain age, you've seen things, and we're also in this era where information is very much available. I think we're doing better than our mothers and their mothers before them, where it was just what they were told. But we can now research these things for ourselves. So we can't just sit there and wait for social media to tell us, or some person on social media to tell me, oh, this is better, this is so natural. What is their motivation for telling you those things? And then also another important thing, if they say there's a study that's been done, who has done that study and who is benefiting from that study? This is information that is publicly available. Let's make use of that information and partner with your medical teams. Discuss these treatments with your medical teams, your choices, your preferences, the reasons why you want to opt for that instead of the other, but keep the conversation going and let it be an exchange that is meaningful. Don't just demonize any treatment. So, like I said, some of these nutritional remedies and supplements and all those things are not harmful themselves. We would never say no, don't take them, but we want to make sure it's not mixing with anything. If you're on other medications, you also want to know you're making the right choice about where you're getting them, what's in there, and what effect you're getting from them, and how safe are you? I would strongly counsel against a person with a blood pressure of 160 odd over whatever it is to say, oh, I'm just gonna exercise and take some beetroot tablets. That's not going to give them the protection they need. So we need to have those conversations from meaningful spaces. So let's keep the conversations going.
Yeah. And I think that's important, particularly where we are as women, in menopause. If you have got a blood pressure really of 160 and you're thinking I'll exercise it away or I'll pray it away, I mean, we need to use discernment, ladies. We've come this far. and we cannot just think that some of these things, it will go away, and the next thing you will see that you will have a stroke or something like that. And we really don't want that. So let's just get to a point where we take some of these things with a pinch of salt, but knowing that we need to manage whatever condition we've got. So I think the last one is really about risks of interactions with the herbal and supplements. What are the risks for these interactions, with the medications like GLP ones, and HRT and chronic disease treatments, because people just think because it's said it's natural, it doesn't really do anything to my body.
So we mentioned that, so with all if you're taking other medications, so there's a number of ways these supplements and remedies can interact. So starting from reducing absorption of your medications. So you're taking your medications as usual, but maybe it's not being absorbed the way it is. One, maybe it alters the stomach pH and alters how that medication is absorbed, or you've got fiber that's sat in there that's affecting the absorption of your medications. And then sometimes these medications enhance the side effects of medication. So for example, you're on a GLP-1 medication and you're taking all these fiber supplements and all that can add to nausea. So your gastric emptying is slower. So things like constipation and all these things can happen as well. So we talk about how our medications are absorbed. Sometimes these supplements actually interact with the medications, denaturing the medications that we're taking. So it then becomes ineffective. So I think another important thing we're speaking about enhancing side effects. So we talk about, for example, if you're on diabetic medications and then you take something that can lower your blood sugars as well, potential for hypoglycemia, for example, low blood sugars and all those things. So we worry about how your medications are absorbed, how they function, and side effects that come with them. And sometimes these other medications these supplements that we're taking can interact with those. So I always say, please actually bring your medication, bring your supplements, your natural, your herbals, bring everything to your appointment. Tell your doctors what you're on. Don't think, oh, it's just a nutritional supplement or whatever. I don't need to tell my doctor. I'm going to I buy this for myself, but just let them know everything you're taking, even the mshonga from your gogos and from whoever. We have on our traditional medications that we use. Let's have that all in context so that we can make a decision. So no one is saying stop taking your things, but it might be okay, maybe hold off this for a second, let's get to where we're getting. Or maybe if you're going to take this, maybe lower this dose, or let's increase the dose of this. So these are important things. And then with the GLP-1s, I mean, it's not a nutritional supplement, for example, but we talk about things like tirzepatide, the Manjaros, and there's Zepbound. They lower the effect of contraceptive medication. So you want to, these are things to be considered, for example, that we need to.
Yeah. And the next thing, we have babies.
Perimenopause, the women do get pregnant.
A lot, eh? The last one, they say
there's a lot. It's a very big topic. I think this is a massive, massive, massive topic, and a lot of these areas that we are just briefly brushing off.
Yeah.
Yeah,
they're huge. They're huge. And I know quite, a lot of women who end up being pregnant, in this phase, thinking that just because I've got irregular menses, I am in menopause, means I cannot have children anymore. No, ladies, if you are still menstruating or there's a drop of blood that is coming out of you, you can still get pregnant. Anyway, I think we've really lost time, and I've just been checking the chats. They're not really, there's nothing really in the chats, no questions. I think you've explained it beautifully, sorry, like Mimi has said. Thank you so much, Mimi. And ladies, so we've come to the end of this section. There's a lot that we've talked about, and I'm sure Limba is tired now, because it's been a long 1.5 hours of just talking. And I mean, at the end of the day, we are here for you. We need to bring this information to you. And I do hope that we've covered essential things that you wanted to hear about. And I think we'll have one more session around weight management in menopause. I will see whether it's going to be in the next 3 weeks or whatever it is, so that you can have time to absorb what we have talked about today.
Just sorry, but final thought on
Yeah.
the hype and all that. We are not the first generation of women to be targeted by hype and unscrupulous marketing.
Yeah.
Women have been trying to manage their weight for over a century. I mean, all the time people were selling tapeworms to manage weight. So we're not the first. But what we have as an advantage today in 2026 is information is available in all forms. There's no secrecy. There's nothing that is not available to you. And then we also have evolved in our dealings with our medical teams, where let's partner with each other. What we need to shut out is the people that are just trying to take advantage of people in their desperation. So especially in our perimenopausal space, where our bodies truly are changing and there are real things happening to us, I think it's a good time to say, whatever you're trying to do, whatever you're going to invest your time in, let it be worth your time, your money, and your health. So let's partner with our medical teams. Let's stay alive.
Please. And also, it's good to just lay it on the table. We do not want secrets of I'm hiding this because my medical doctor will say that. Let's talk about it. Let's get to a point of understanding. If your medical doctor is really not coming to the party in talking to you and understanding, I think there is a real problem, there. I know there are quite a lot of doctors here. Please, let's just meet our patients where they are. We cannot just think that, we can bulldoze them into one side of the equation. Let's understand that the human, as much as you are human, and knowing that you don't necessarily do it according to book, also let's just ensure that we put our patients into mind. So anything else you want to add, Vimbai, before I just close off? Anybody
Biology
else?
and evidence, use that to make your decisions. You are a lot more capable of making genuine decisions for yourself than you believe you are. And there's a lot of support out there. So a lot of these things that you're encountering are not new to you. Someone somewhere has studied, has dealt with it. A lot of people have come with it. And guess what? There's people who've gone to school who've actually deal with this every day. And we see all this. I'm telling you, I spend all day talking about GLP-1s, about fat bums, fat this. These are real things. So let's reach out. Let's take care of ourselves. Let's continue that grace in our decisions that we're making, and look after ourselves.
Yeah, and beautiful women, we'll continue our conversations, and just know that you are not alone. We're here to support you. And that woman sitting next to you, if you hear she is 45, 46, just know you're in the same boat.
We're all dealing with it.
We are dealing with it. We are going through the process. It is what it is. And as a woman who's got ovaries, this is what is going to happen to you. So thank you so much. We'll keep in touch, and I'll tell you when the next session will be. And we're also looking at pulling gynecologists, talking about relationships, and talking about HRT, and talking about the male side of things around libido. Why does it seem like it's all our fault that there is nothing happening in the houses there around sex? So we'll talk about everything. So thank you so much. Have a good evening, and see you next time.